Hello everyone. In this video, I will talk about Guillain-Barré Syndrome or GBS. We will discuss in this video about introduction, clinical features, pathophysiology, how we can diagnose this condition, and treatment. We will not discuss in details about this GBS, but we will discuss the high topic for exam. So let's start. GBS is an autoimmune demyelinating disorder, and it leads to paralysis, mainly ascending paralysis, and which we will discuss in later. It is the most common cause of acute flaccid paralysis in the worldwide. Now, if I want to talk about the epidemiology, it is not common disease. It is a rare condition, about 20 cases per million. And males are more commonly affected than females. So what are the causes of this GBS? It may occur following an antecedent infection, mainly GI or respiratory infection. And the common agent of these infections are Campylobacter jejuni, cytomegalovirus, or Epstein-Barr virus. Or it may occur following vaccination like influenza or COVID-19. Now let's talk about the pathophysiology of GBS. GBS is an immune-mediated reaction which causes neuropathy. It occurs after an antecedent infection. So when an infectious agent enters into the blood, our immune system produces antibody to destroy that antigen. But that antigen has similarity to our own nerve cell. As a result, molecular mimicry occurs and production of ganglioside antibody. So it may be either demyelinating or axonal type. Here is an example. The lipopolysaccharide of the outer membrane of bacteria like Campylobacter, which resembles like the gangliosides of peripheral nervous system. So this will lead to antibody bindings, activation of the complement system, and this will lead to nerve injury. So our immune cell will go to that injury point and macrophage start scavenging. If you want to know more about this pathophysiology, check the link in the description. So what are the clinical features of GBS? Usually after the original symptom, there may be antecedent infection, which is more commonly occurs. And this antecedent infection may be due to GI infection. Typically Campylobacter jejuni, which is the most common precipitating infection or infectious agent, usually present with bloody or watery diarrhea. Or there may be respiratory infection due to influenza viral infection, which usually present with fever and cough. So after that antecedent infection, the original symptom or classical clinical features which usually develop. And that classical features occurs 1 to 6 weeks after the infectious or after the antecedent infection. And the classical symptoms is the ascending type of weakness and paralysis, which is usually symmetrical and that begins from the lower limb and they ascend upwards. There may be areflexia or hyporeflexia, as this GBS typically involve the lower motor neuron. There may be symmetric paresthesia, loss of proprioception, and vibration. So when this ascending type of weakness involves the respiratory muscle, there may be respiratory failure. So this is a neurological emergency and we should treat it promptly. So what are the other clinical features? GBS may also involve the autonomic system and there may be autonomic dysfunction like orthostatic hypotension, urinary retention, cardiac arrhythmia, sinus tachycardia, and this may cause the significant cause of mortality and morbidity. There may be autonomic involvement, autonomic mental status, so which is also known as Bickerstaff encephalitis. There may be dysphagia and facial nerve involvement. What are the variants of GBS? First one is AITP or acute inflammatory demyelinating polyneuropathy, which is the most common variant. We know that GBS may be either demyelinating or axonal type. Among them, AITP is the most common and it is the demyelinating variety. Next is Miller-Fisher syndrome, which involves anti-GQ1B antibodies. GQ1B antigen is usually predominant around the eye or ocular region. So in Miller-Fisher syndrome, we will find a triad of ophthalmoplegia, areflexia, and ataxia. So when this Miller-Fisher syndrome is combined with loss of consciousness, this is also known as Bickerstaff encephalitis. In AMAN or acute motor axonal neuropathy, there is involvement of motor systems and development of anti-GM1 antibodies. This is axonal variety. In AMSAN or acute motor and sensory axonal neuropathy, that involves both motor and sensory system, and this is also axonal variety. In pharyngeal cervical brachial variant, it typically involves the corresponding muscles. How can we diagnose this GBS? We can diagnose it clinically. So in clinically, when we see the patient with progressive symmetrical weakness that involves more than one limb with hypo or areflexia, an acute onset following and an antecedent infection, we can suspect that this is a case of GBS. We can do the EMG and nerve conduction test to confirm if it is demyelinating or axonal type. We can also do the lumbar puncture, but we have to do it after at least 7 days of onset. Otherwise, we will not get the appropriate result. In lumbar puncture, we will find normal WBC with elevated CSF protein, which is also known as albuminocytological dissociation. How can we treat this GBS? We can give IV immunoglobulin, which should be given as early as possible, because the first we start this immunoglobulin, the better the outcome. We can also do the plasmapheresis, where we can isolate the antibodies that has developed. We have to do the intubation if respiratory muscle is involved or respiratory failure develops. And there is no role of steroid. We can see some sort of improvement in CIDP, but not on GBS. So how is the prognosis of this GBS? Axonal variety has the worst outcome and demyelinating variety has the good outcome. Also, the patient with old age and delayed treatment, which means that when we delay the start of immunoglobulin, will often worsen the outcome.